I want to warmly welcome you and to thank you for being here to join us in this discussion. And we'll be discussing a very important topic on hospital detention for non-payment of hospital bills, legal and health financing options. This is a very important webinar and a discussion for us at this time, given the commitments made by countries to UHC, to ensuring social protection for everyone. The objectives of this webinar, we want to clearly state that hospital detention for non-payment of user charges is illegal. It's a human rights violation and has to be stopped immediately. And in this webinar, we also seek to raise awareness on the issue and the importance of addressing it, including among the health financing community. And also discuss the measures that countries can implement with the support from the international community to end hospital detention. Through this webinar, we'll share personal experiences on hospital detention, and we'll also have a discussion on the policy brief from WHO that has looked at legal implication, that has looked at financial implication, but also the magnitude of the problem and a proposal of possible options to address this problem. But also here, a reflection of countries. What are countries doing to address this problem? And we also hear perspectives from some of the speakers, their perspectives on stopping hospital detention. And then we'll have a discussion on the floor on this. Now, we are fortunate to have a very outstanding group of speakers from countries, from WHO, from different agencies who will be discussing this topic with us this afternoon. And I will be introducing them as we go through the sessions. But I want, first of all, to introduce myself. My name is Juliet Nabionga Orem, and I work for the World Health Organization. And I head the Health Financing and Governance Program at the Intercountry Support Team for Eastern Southern Africa. But I also lead the Health Financing and Investment Program at the WHO Africa Regional Office. So now I want to introduce to you the first set of speakers who will be talking about the definition issues, the experience issues, but also touch on the work that WHO has done in this regard. Our first speaker this afternoon will be Annette Bosibori Omoyo, who is a graduate from Moi University with a Bachelor of Law degree. She then worked in the sunny Kenya with the USAID Parliamentary Strengthening Program at the Kenya National Assembly. Annette currently works with the Kenya Law Reform Commission as a Principal Legislative Counsel, and she's recently won the Youth of Excellence Scholarship to undertake study in the International Economic Law from the East China University of Political Science and Law. Annette will define what hospital detention is, but she also present the human side of the problem with a small case. And again, this we'll have presenters from WHO. We'll have Dave Clark, who is a lawyer and also specializes in health law and policy, and is currently leads the work of WHO at headquarter level in Geneva on 3 main topics: engaging the private sector to help achieve UHC, using the law to deliver UHC, and anti-corruption, transparency, and accountability in health. Before joining WHO, Dave worked as a lawyer for the New Zealand Ministry of Health and on a health reforms project for the government of Trinidad and Tobago. He then co-founded and worked as a partner in the public policy consulting company for governments, non-government organizations, and development agencies. We'll also have another speaker from WHO, Inka Matao, who is a senior health financing specialist at the Department of Health Systems and Governance and Financing at WHO with over 20 years of experience in this work. Inka leads the global work on strategic purchasing for UHC with a focus on mixed provider payment systems, governance arrangements for purchasing, and digital technologies for health financing. Her work involves technical support and policy advice on numerous countries and various regions, conceptual work to synthesize evidence on what works for UHC, and capacity strengthening activities. Inke holds a master's degree and a PhD from the London School of Economics. So this will be our first set of presenters this afternoon. But before going to the presenters, we want to find out the degree of awareness of this program among the participants this afternoon. And on this, I want to put up our poll question just for us to scan the extent of awareness, and then we'll go into the presentation and discussions. We just want to take a poll to see how much do we know about this problem. This is, there's a good side to the poll, but also a downside to the poll. It's good that we all know that this is a problem. So we are looking forward to a very fruitful discussion on possible options to address the problem. And also I take note of the law, 17% said no. I think you also look at it as an opportunity to raise awareness such that we can all pool efforts, pool resources, expertise, and also the networks that we may have to really contribute to solving the problem. So on this note, may I invite you, Annette, to make your brief presentation about your, to raise awareness on this problem, but also a personal lesson.
I'm just going to briefly introduce what hospital detention is and hospital detention practice. So hospital detention can be described as the refusal by a hospital to release a patient after they've already received their medical discharge. So sometimes the release is of a living patient, and sometimes it's for a patient who is already deceased. So there is refusal of releasing the deceased person's bodies to the families and to the patients. And this is solely because this person is unable to pay their hospital bills. There are also cases where how hospital detention practice has manifested itself, especially I'm from Kenya, so I'll only be using examples which I'm familiar with, is sometimes the families are, they have no choice but to even abandon their loved ones or even refuse to claim the bodies. And so those corpses must be discarded in anonymous graves. Now, the problem with this practice is that hospital detention actuates hospital overcrowding and hence increasing the risk of infection. As we go along the discussions, I think later on in the webinar, I will be highlighting a recent case, a 2018 case of Gideon Kilundu and Daniel Kilundu and against a hospital where a man's son was actually involved in a road accident. And even after receiving medical discharge, the hospital detained him because he could not pay his bill. So there's hospital detention and there's hospital detention practices which are quite harmful, but we'll be looking and discussing more about this as we go along. Thank you so much, Juliet, for that. I think I'm done with the brief introduction. Thank you. Over to you.
Thank you so much, Annette, and keeping to the time, much appreciated. Now I'll straight away invite Dave and Inka, who will take us through the WHO policy brief, looking at the legal and health financing challenges and also possible solutions from that perspective. So over to you, Dave and Inka.
Thank you very much, Juliet. Thank you very much, Annette. It's really great to have Annette here today so she can give us some first-hand experience of what this terrible practice means for families in many parts of the world. So this is a problem that has actually been a long-standing problem. Those of you who are aware of the issue will know that it's not a new issue. Unfortunately, it's become a common practice in some parts of the world. One of the problems that we face is we don't have a lot of data about it. Obviously, because of the nature of the practice, it's really difficult to get accurate estimates of how many people are actually involved, but we're assuming, based on some information that we do have and some of the work that Rob Yates has done, that this actually affects not just the patients, but also their families. So we're probably looking at hundreds of thousands of people who are affected every year by this practice. Unfortunately, it disproportionately affects the poor and the most vulnerable, and in particular women and children with the weakest voice in health systems. And it seems to impact most on people who have a need for high-cost inpatient care, and it seems to disproportionately affect those in hospital for maternal care. From a legal perspective, hospital detention is not justified in any way. It's It's in violation of a number of human rights and international law commitments that our member states have signed up to, including the right to health, the right not to be subject to cruel, inhuman and degrading treatment, the right to liberty and security of persons, the right not to be detained for non-payment of debts, and the right to dignity. So in essence, when it happens in countries, it's actually contrary to international law. Also from WHO's point of view, and Juliet made this point at the start, we're obviously concerned with supporting countries to reach universal health coverage, and hospital detention directly conflicts with UHC and its objectives. It's contrary to access to needed health services, it's contrary to patient-centered care, it's contrary to financial protection, and it is contrary to equity and service use. And the reasons why are well summarized on this slide. What we find in many countries is, although countries have signed up to various international agreements around standards which in theory should make this practice illegal, what we see in practice in countries is a very patchy set of circumstances about implementation. We find that in some countries, domestic laws have been used insufficiently to implement international human rights. We also find that there are many implementation problems and knowledge gaps where people simply don't understand that the practice is illegal. In many countries, and I'm sure Annette will be able to comment on this, we find that people face barriers to making complaints and seeking legal redress. And we also find that there are challenges in relation to a lack of collaboration to address this problem. I mean, there are legal solutions, and some countries have acted acted on this problem. So one thing that countries can do is to ban the practice. They can actually set out in their law this practice is illegal. WHO is keen and willing to work with any country to help them to implement and enforce international commitments and their current domestic laws. We also support the creation of effective mechanisms for patient rights, such as patient complaints mechanisms and the right to redress to courts and other complaints bodies, such as ombudspersons. And we're here to help member states to help address any underlying governance problems and accountability failures which are leading to these practices. So we are really here to help. We are very keen to end this long-standing practice. I'm now going to pass over to my colleague Inka, because as well as legal issues, there are many financial health financing issues which affect this practice. Over to Inka.
So hello to everybody. Let me take on the health financing side. Now, the existence of hospital detention points to weaknesses in the health financing system. It's clear that this is not a reason, nor an excuse for detaining pensions when they cannot pay. However, it's very important actually to understand the weaknesses so as to then build upon this to develop solutions or measures. Now, first, revenue raising policies can be inadequate, and hence their implementation leads to inequitable and insufficient revenue raising, and in combination with fragmented pooling and inadequate purchasing arrangements that fail to get the funds to the frontline providers by setting the right incentives, it leads to a situation where actually there are insufficient funds at provider level. So this also then results in inadequate coverage for people and limited financial protection. So let's look into this limited health coverage. This is the case because even when there are free healthcare policies in place, they may not function well. And we also have to keep in mind that they only cover a specific set of services, often quite focused and hence limited to a specific set of services. Now, exemption mechanisms may be the last resort at the provider level, but again, we also know that in various cases, they're poorly functioning and actually rules are not well designed and they're not followed. Now, the rules are not followed because actually health providers often rely heavily on user charges. User charges at the end of the day are out of pockets for the patients. And so that leads to a situation where, or that's in the context of insufficient government budget allocations to the facility. Now, it's clear, unpaid hospital bills are lost hospital revenues, basically, especially when hospitals actually largely rely on the user charges. We also have to keep in mind that the revenues from their user charges are often the only source of funds over which hospitals actually have some discretion. Now, in order to address the weaknesses in the health financing system, comprehensive health financing system reforms are needed, and these reforms actually must be aligned across the three health financing functions. Now, here's a list of some of the key principles to guide reform. I'm not actually going through them in all detail, just to maybe point out two, which are absolutely fundamental and key. There must be increased reliance on domestic public funding, and also there is need to reduce the fragmentation in the health financing system so as to increase redistributive capacity. And third, and I think the remaining bullet points that you see here, they relate to purchasing. The purchasing arrangements have to be improved so as to actually ultimately get funds to the providers and set the right incentives. Now, this is nothing new in terms of the core messages. Of course, these principles have to be tailored to the country context, but nonetheless, there is a lot of evidence on what works, what are appropriate arrangements and mechanisms. For example, some of them outlined in the document that I have put down here at the bottom, Financing for Universal Health Coverage, the do's and the don'ts. Also in the recently published Health Financing Progress Matrix, there's an outline of desirable health financing attributes, and that again gives guidance for health financing reform. So it's clear that these comprehensive health financing reforms don't happen overnight, and actually they can take years, as we see, especially when it gets political, in particular with respect to pooling reform. But countries can think of some shortish medium-term measures to avoid that hospitals actually end up having unclaimed, uncompensated care, unpaid bills. So here are a few points outlined. More options are actually in our policy brief. But before going into this, let's also mention that hospitals could put more focus on offering realistic repayment plans or delayed payment schedules for patients who are in principle able to pay in rates or to pay part of it. But we also have to be clear that this will not happen very poor patients. So this is rather a measure for patients that are better off, but that may not have right away a large amount to pay their hospital. So the first measure is to actually think again of exemption mechanisms, introduce them, revive them, or specify them with clear rules on eligibility. So which population groups or along which criteria can people actually benefit from exemption, and what are the services to be exempted. Now that's one side, the exemption. At the same time, we need to think of how hospitals are actually reimbursed and how they get their bills paid. So one could think of an additional budget line or a budget set aside at the facility level. You can think of internal cross-subsidization within the hospital. One could also think of an additional budget at the level of the purchaser, which health facilities then can access through a specific claims mechanism. Just to give a few examples, in the Philippines, hospitals are not allowed to charge co-payments from indigent persons who are actually identified by the Department of Social Welfare and Development. In Chad, there was a mechanism in place for which social workers at health facilities identify patients to benefit from fee exemption schemes for emergency care, and the social workers then filled in a claim for reimbursement by the Ministry of Public Health. And in fact, we will also hear from a Zambian colleague just later in the webinar about a mechanism in place in Zambia. Another measure that actually goes along with the first one is to actually make the use of hospital budgets more flexible. It's really now a reason to overcome rigid line item budgets. Third, free healthcare policies actually have shown to be effective when they're well designed, when they come along with funding. So one potential is also to think about free healthcare policy for emergency care for specific population group. It cannot certainly be, to be discussed at country level, but it may be difficult to have it for the whole population. But again, free healthcare policies can come along with specific eligibility criteria. Burundi, in fact, provides an interesting example of a free healthcare policy. It introduced fee exemptions for maternity care and for children below 5. Initially, this was funded through donor support. And in fact, this policy was also an explicit first step towards ending hospital detention. And the fourth point that I just want to briefly point out here, one can also think of having a more flexible use of donor funds that hospitals receive for specific programs, often funding for vertical programs coming in. The question is really, should donors or should NGOs provide funds to hospitals that engage in the practice of detaining patients? One could say that stopping hospital detention could be a condition for funds in that hospital. Now, it's clear that for all those measures, adequate funding has to be available, and it has to reach the facilities effectively. And that in itself is a big challenge. So you may actually ask, well, are these really short-term measures? Are these interim measures? And I think that's a very fair question. And I would suggest actually that we may come back to this in the discussion. So let me go to a few conclusions and what is needed to get the practice of hospital detention ended. Again, these are just a few points. There are more in our policy brief, but we certainly want to hear more from our country speakers and discussants. And above all, we would like to hear from you, from the participants, to learn more about your country experiences. So here are 4 points. It's clear that the practice of hospital detention has to be stopped right away. And for that, it requires strengthening the rule of law to ensure legal protection. That will also call for strengthening collaboration across actors and across sectors, specifically between the legal and the health sector. Secondly, there's need, as I had outlined, to strengthen the health financing system so as to enlarge financial protection and to get funding to hospitals. Exemption mechanisms, reviving them, making them functional may be an option until broader health coverage schemes are well functioning and are in place. It's clear that there is need for support from global actors and from development partners. That may be financially, that may be through technical assistance, as well as policy dialogue and above all advocacy. And just to get us thinking about how more information and data on this practice could actually be collected, Dave was saying in the beginning that in fact there is lack of data. So there's need to better understand the magnitude of the problem and to monitor it. One could think potentially of a question on hospital detention or denial of care in national household surveys. We would actually like to hear from you on the following 3 questions. So you are invited to share your country experience on the following points. First, are there specific legal measures applied in your country to stop hospital detention? Second, are there specific health financing support measures in place in your country to support patients that cannot pay their hospital bills? So we're not talking of broader health financing reforms or broader health coverage schemes, but like very specific measures that hospitals actually have chosen to take up. And third, and I guess maybe most important, what is needed to end the practice of hospital level at country level and at global level? And with that, thank you very much for your attention, and I hand over to Julia. Thank you.
Now that we've heard the definition and we've heard the policy brief from WHO, I want us to take it to the next question to really appreciate what's happening in countries. Okay, 70% yes, say yes, it occurs in the country, and no, those are the lucky ones, but also we take note of the concern of the data systems, whether we are picking the problem or not. So now I think the next session we are going to move to what are countries doing? And we are going to hear reflections from countries, what is being done. And on this, I'm pleased again to introduce the 2 speakers for this session. One of them is Annette, who spoke earlier, and just to remind that Annette works with the Kenya Law Reform Commission as a principal legislative counsel. So she'll be speaking to us on what is being done in Kenya to fight hospital detention and how Kenya is introducing legal measures against the practice. Then we'll also hear from a colleague from Zambia, George Tafona. George works for the Ministry of Health in Zambia and is in charge of the psychiatric social services and public relations. This department advocates for and protects the rights of the patients. He holds a master's in behavioral science and a PhD in social psychology from Karen University and a postgraduate in mental health law and human rights from the Indian Law Society College. David will take it to the provider perspective. And it will reflect on the health financing related measures that have been put in place to avoid hospital having non-paid bills. So I invite you, Annette, to give us your reflection on what is being done in Kenya to address this problem.
Thank you, Juliet, once again for the introduction. So I'm just going to give a perspective on hospital detention practices in Kenya. And studies have revealed that the underlying causes of hospital detention in Kenya is largely associated with accountability mechanisms, which need to be improved. We also have a very weak regulation of the private health sector. So if you are detained in a public hospital, the public hospital is able to link you with a social protection program. But unfortunately, if you are hospitalized in private healthcare, then the government has no reach whatsoever with regards to the public health sector. So we are saying that there is quite some weak regulation with regards to the private health sector to ease on hospital detention practice. Another problem that we have encountered that is a cause of hospital detention practice in Kenya is just having inadequate financial protection from health costs. The uptake of insurance is not so high. It's quite low and only left for the affluent. So we have a bigger chunk of persons who, in terms of their uptake of financial protection from health costs, is quite dismal. Then there's subsequent higher out-of-pocket expenses within our healthcare system in Kenya, which particularly inflicts a lot of financial hardship for the poor. Lastly, and of course, this is just not it, their health inequity remains while poor populations have very limited access to medical care and in terms even of quality and the risks to be detained inside a hospital if they cannot pay hospital bills. So a lot of people also, this has played even in part in terms of even reaching out to seek healthcare is becoming quite a problem even for families who are from the poor populations. In 2010, Kenya enacted a new constitution. And in this new constitution, one of the key fundamental gains was that Kenya recognized the Bill of Rights and a wide array of rights under that Bill of Rights. And if we look at Article 19, the Bill of Rights, which is quite integral in our democratic space, says that recognizes the protection of human rights and fundamental rights and freedoms, which require the preservation of the dignity of individuals and communities and to promote social justice and the realization of the potential of all human beings. We also have an Article 29 within our constitution, which also provides for the freedom and the security of the person, which includes the right not to be deprived of any freedom arbitrarily or without any just cause. Another article is 28 that provides that every person has the inherent dignity and the right to have their dignity respected and protected. And Article 39 also provides that every person has the right to freedom of movement. So Article 21 recognizes the state's duty for every state organ to actually observe, respect, protect, promote, fulfill the rights and fundamental freedoms within this Bill of Rights. So the state has an obligation to take legislative, policy, and other measures to ensure that the Bill of Rights is actually enshrined. So for Kenya, our legal system has already lifted in terms of the recognition of this Bill of Rights. So with regards to hospital detention practices, we already have the legal platform on the supreme law to actually help prevent these health detention practices. However, there is currently no legislation to prevent this. We are still seeing pre-admission policies, that are stemming from the private sector, and even persons being forced to sign hospital undertakings to pay. And I'm going to illustrate this with one case because there've been numerous cases in court, but there's a case of a man called Gideon Kilundu and Daniel Kilundu Mwenga versus a hospital within Nairobi called the Nairobi Women's Hospital. Now, Daniel Kilundu is the son of Gideon, and he was involved in a road traffic accident. And then, as usual, he was rushed to hospital and admitted to the intensive care unit. Now, a month later, he recovered. but was detained in the hospital due to non-payment of the bill. So his family decided to go to court for purposes of ensuring that their loved one can actually be released from the hospital, arguing that detention is actually a violation of the fundamental human rights as enshrined within our Kenyan constitution. Now, for Kenya, of course, as I've said, it was not the first time that Kenya was faced with such cases. We have had numerous cases in court, and most courts have, in all instances, held the view that detention for inability to pay medical bills is actually unlawful, arbitrary, and unconstitutional. So the court in this case, why I chose to discuss this case is because the court brought in two competing interests. One, within the rights, that there's the right for any person to enjoy their liberty and freedom of movement, but at the same time, the hospital also has a right to property, which in other words, the hospital needs to be paid. And even in our discussions, we say that there's a need to balance. So you can see in Kenya has already begun the discussions towards balancing these two competing interests. So the court had the arguments from both parties. For example, the court underlined the fact that the man could actually have been transferred to a public hospital and received care at a cheaper cost, but knowingly decided to remain in the care of the private hospital. And this shows you how deeply entrenched the hospital detention practice is, that it is forcing persons to actually seek care that is affordable. So if you, and we can see this sometimes when people get accidents in Kenya, that people, first of all, don't just think of the nearest hospital that is available for care, but they must have at the back of their minds, what is the nearest, cheapest hospital? And this should not be the case even as we move towards the UHC. So consequently, the judge made two determinations, declared that the continued detention of this man was actually arbitrary and unlawful, and the hospital was actually given an order to release the man from the unlawful detention. So as you can see, that is the case of Kenya, and there are many, quite a number of cases, even for people whose, bodies are. So those are the case I wanted to share, and I want to summarize and say, then what are the solutions for Kenya to consider? And I feel that in the short term, government healthcare policies in Kenya must rigorously seek to stop hospital detention because it is harming a lot of persons. It is hurting a lot of people. There are a lot of people who are crying. There are cases even for the release of loved ones. We have persons who are still crying 2 years, 3 years, 4 years later. They've never gotten a chance to bury their loved ones because they have not paid the hospitals. There are people who have pawned their properties to the hospitals. It's largely people are getting quite poor because of seeking hospital care. In the short term also, we want to have more critical awareness of this problem and trigger policymakers to actually do something about this. But in the long term, we are hoping that Kenya will implement the universal health insurance, which definitely shall significantly improve Kenya's population access to medical services and achieve positive health outcomes. Then the implementation of the UHC, which means that it shall preclude patients from being rushed into prolonged poverty while paying for healthcare services out of their pockets, thus preventing hospital detention. The UHC definitely shall serve to stimulate, as the presentation had been done earlier by one of our panelists, to stimulate durable development, reduce poverty, economic growth, and decline in social economic inequality. So I would like to end my presentation there for now, even as we continue to discuss along the webinar. I want to yield back to Juliet. Thank you so much.
Thank you very much, Annette. I want to straight away go to George, who will provide a provider perspective and reflect on health financing related measures that have been put in place to avoid hospital detention and the non-payment of bills from the Zambia perspective. So George, over to you, please, and you have 4 minutes. Thank you.
Good afternoon, Juliet. As much as we have heard from each and every speaker, we have heard that health is a human right and everyone is entitled to good and holistic health. any obstacle that comes in between is a violation of human rights. And user fee should not prevent people from accessing or having universal health coverage. So in order to meet some of the goals, in 1993, in Zambia, they introduced user fee in all hospitals. And it came at a time when really Zambia had a lot of people that were impoverished. And yet they wanted to meet the targets as per se. Now, this saw that a lot of people were turned down, and it was discovered that a lot of vulnerable people were seeking traditional medicine instead of going for conventional medicine. It stopped people accessing health services, of which it also increased the mortality in the country for the poor communities. And after the survey, which was done in 2002, 2003 to establish that, effective 2006, the President of the Republic of Zambia abolished user fees in all primary healthcare facilities. And that on itself, it saw that 55% of people started seeking health facilities. And it was discovered that the standard of the poor increased in all the rural Zambia. People were able to go to these primary health facilities, of which I can talk of the rural and urban clinics, district hospitals, and vice versa. However, in tertiary hospitals, user fees are still being charged. But if a patient passes through the lower hospital from the clinic, that's when he is referred to a higher hospital, that means a waiver is given because they have followed the procedure. We have basically got 3 universities teaching hospitals in Zambia. We have almost about 12 central hospitals. We have a good number of general hospitals in all the provincial headquarters, and even in some more towns, we have general hospitals. And then we have so many first level hospitals that have just been introduced in Zambia. And if you look at it, you find that in general hospitals, those are secondary institutions, and the centrals that are tertiary, they are actually charging those user fees. So instead of detaining people, the Zambian government introduced offices of social work in all the secondary and tertiary hospitals. What happens is, if a client comes into a hospital and they are unable to pay, the social workers have to do the social study, and they'll analyze the patient. And after that, they'll have to present it to the head of that institution for possible exemption. And 3/4, or I would say all the patients that are vulnerable are exempted from user fee. They are able to access health facilities. Then not only that, if we look at the social workers, they also look at different levels of human standing. They do what we call some assessments according to levels. So in levels, we have exemptions that are done at the patient's own capacity. So you find that the social workers will actually ask the client to find out how much they can afford. So if they tell them how much they can afford, they are able to exempt them at that level. Then we have got another part, which is the public welfare assistance. This applies to impotent patients like persons with mental health problems, those destitutes, those in disasters or emergencies. You know, these people, more especially the persons with mental health problems, they cannot fight on the common market. So what the government has done is these are given an exemption of 100%, depending on the case that comes. Then we have also what we call on humanitarian. On humanitarian, it happens from case to case. Like if there's a disaster, you may find that someone may say to be in a well-to-do, but then that disaster will cause them to be in poverty within a day. So these people, they can be issued what we call exemption through a humanitarian background, or again, in emergencies, they actually get those exemptions. Then how now do hospitals get reimbursed if, let's say, they do such exemptions? So there are mechanisms that the government has put in place to assist hospitals, where the government provides a monthly grant that is released by the Ministry of Finance to all health facilities to meet some of the requirements of the hospitals because of the modalities that have been put in place. Then there's also what we are calling the National Health Insurance Scheme. This is done through employees' contributions, and also the Social Security Scheme administered by the Department of Social Welfare. So all these are some of the modalities. And of course, we cannot rule out the donor reinforcement. So hospitals are cushioned by the donor reinforcements, of which we appreciate a lot. I think this is how much I can present as at now. Thank you, Juliet.
Thank you so much, George. We really do appreciate the provider perspective. Now, ladies and gentlemen, I want us to take it to our panelists. So for this last speaker group, I want to introduce Rob Yates, who is a political health economist specializing in UHC and progressive health financing. Rob is the executive director of the Center for Universal Health at Chatham House. He's an honorary associate professor at the London School of Hygiene and Tropical Medicine, and a consultant to the elders on health on their UHC program. His principal area of expertise is in the political economy of UHC, advising political leaders and the governments on how to plan, finance, and implement UHC reforms. Rob will be speaking to us about the global and national actions required to end hospital detention and highlight gaps in knowledge, which call for further research. Again, we are lucky to have Alicia Eli Yamin, who is currently a lecturer on law and senior fellow at the Friedholm Center at Harvard Law School and senior advisor to human rights at the Global Health Justice Organization, Partners in Health. Yamin also serves on the UN Secretary General's Independent Accountability Panel for Women's and Children's and Adolescents' Health in Sustainable Development Goals, and the WHO Technical Advisory Group on Health Technology Assessment. Yamin regularly provides expert testimony and guidance to national and supranational tribunals and legislative bodies around the globe in relation to the application of international and constitutional law to health issues. She was the only non-Kenyan appointed to the Oversight Committee for Health Matters of the Constitutional Implementation Commission in relation to the 2010 Kenya Constitution. And now allow me to invite Rob Yates to make his 8-minute intervention. So Rob, you have the floor.
Thank you very much indeed, Juliet, and greetings from London, everyone. Yes, so I'm Robert Yates. I'm Executive Director of the Centre for Universal Health in Chatham House. And this is a topic I've been studying for a number of years. And like sort of a lot of people was unaware of it initially, but it was the really impressive work done by Human Rights Watch in Burundi that first brought this to my attention, where the scale of hospital detentions was absolutely enormous. And you can see that the public hospitals had virtually been turned into debtors' prisons because, you know, they were just so full of people who couldn't pay their user fees. And what was very interesting about that example, and I think it is perhaps where I'd like to focus discussions now, was on how quickly they managed to overcome this problem and basically end the practice. And that was with political pressure on the president to acknowledge that this was an outrageous human rights abuse, you know, to lock up a woman and a baby in a hospital for weeks, if not months on end, you know, with sort of really sort of graphic stories of them being denied treatment and food in some examples as well. And to the credit to the president, he was horrified when he found out about this and went to see the facilities, and very quickly recognized that this was a dreadful thing that was not only impacting on hundreds of, if not thousands of women and babies over a period of time, but was discouraging people from going anywhere near the public hospitals for fear that this might happen to them as well. So the president quite simply banned the practice. You know, he went on sort of national television, I believe, and said, you know, that they were going to ban the practice of medical detentions. But he also realized that there was a systemic health financing problem, which WHO have highlighted very eloquently in this excellent report, that the user fees income needed to be replaced with public financing. And that by doing that, by getting rid of the user fees, by banning medical detentions, by increasing public financing, you can get onto a trajectory that we recognize as much more akin to universal health coverage. And it was astonishing in Burundi that within the period of about 2 or 3 years, the number of babies born in health units went from 1 in 5, when people were fearful of being locked up in the hospitals, to 75, 80%. You know, the majority of babies were then born in health units. Now, this was in 2005, 2006, when Burundi, I believe, was one of the poorest countries in the world. So if Burundi could do it 15 years ago, why can't every country do it now? And you know, that one thing I've learned, you know, from today's webinar is just how prevalent this still is. I mean, I was gobsmacked to see, you know, 70% of our participants today say this is continuing in their country. Now, you might say that we're a self-selecting group of people who are interested in this topic, but let's not kid ourselves that you know, this is rare and doesn't happen very often, and this is highly unusual. And I don't think we should kid ourselves just how bad this is. I mean, for any country claiming to be making any progress to UHC, this should be, you know, recognized as a red card offense. You know, this is off the scale bad on, you know, a measure of UHC. So I would like to think about the sort of the practical ways that we could be putting pressure on governments, but also recognizing, I think, the role of international agencies in being complicit in this for so long. You know, it is very noticeable that a lot of people, when you talk about this at conferences and privately, they say, oh yes, you know, we do know this happens here, it's terrible, isn't it? But then don't do anything about it. And, you know, that I put my hand on my heart and say that you know, when I was a DFID health advisor, you know, sort of, you know, that I wasn't really engaged in this at the time. I mean, I like to think that I've sort of tried to sort of take this up sort of more latterly, but we should collectively be putting pressure on ourselves. So that means WHO, UNICEF, the World Bank, all the multilaterals, all the bilaterals, you know, to really hold governments to account on this. And I think, you know, the solution, you know, as the report says, is around using the ability to ban medical detentions to flag, you know, how poorly the health system is being financed, and put pressure on governments to increase public financing. And as I say, that, you know, the fact that you know, Burundi's been able to do this, there are many other countries in sub-Saharan Africa that haven't had this problem because they haven't sort of charged the user fees, and you know that they banned this practice a long time ago. So I believe that through mechanisms like the UHC commitments process, we should be calling out and red carding countries that do this. But this is quite an easy problem to deal with, and I think by the president, and it is a head of state issue. This isn't something that can be left to the Ministry of Health. By calling on the heads of state to ban this practice, but simultaneously increasing public financing and removing user fees, is a very straightforward solution to this. This isn't difficult, and we can tackle it. Thank you.
Thank you so much, Rob. And I want to pose a very quick question to you that I want you to answer in just 1 minute. You clearly identify the roles for actors at a global, national, and the different levels. But the problem we've had is compliance. And you know, the days of swap are here with us. We know the commitments in these partnership frameworks, but compliance has always been a problem. What do you think we can do differently?
Well, that's a very good question, Julia. And of course, it means that we in the health sector and health actors need to be working much more closely with the judiciary, with the police, because, you know, if this is, you know, breaking the law, you know, it's breaking international law, and it should be the case that be it public or private sector, any hospital management where, you know, which is locking up women and babies, particularly in terms of a pandemic, you know, you have a pandemic of infectious disease, you're putting these people's lives at risk by keeping them in hospitals. And so we should be sort of teaming up. This is why I think the media play a very big role in this as well. And to berate, you know, sort of the hospital management and you know, those that continue to lock up patients, they should be arrested and taken to court and potentially put in jail. I mean, you're detaining people illegally. And if, say, a restaurant owner were to sort of lock up people who haven't paid for their meal in the kitchens or something, for you know, there would be an outcry, you know. So why should it be any different to hospitals?
Thank you so much, Rob. Thank you. And I want to move to Alicia, who will talk to us about what else do we need to do? Political commitment, yes, but is that all?
Okay, thank you very much, Juliet. And I also want to acknowledge on behalf of the Independent Accountability Panel that we did a case study on the lack of accountability for detentions in Kenya in our 2020 report. The WHO report, I think, is really incredibly laudable for not just denouncing this practice, but really talking about the challenges to implementation, the political economy issues, the reimbursement mechanisms that are challenging, whether they're through indigence cards or exemptions on a case-by-case basis granted by providers. And I want to point to two questions, one of which has already been raised by Annette, and I will focus my remarks on Kenya because that's the context I know best. One of which is the public-private question. In Kenya, this is not a legislative law question. This is a regulatory and compliance gap question. As Annette suggested, the Constitution of 2010 is incredibly emancipatory. There is, in addition to the rights that she listed, Article 43 sets out a right to health. And I had the privilege of being on the Constitutional Implementation Commission, where the leader of that commission, Catherine Muma, saw very clearly the need to address these issues and to empower civil society to note disrespect and abuse in facilities, up and including detention. The other issue in Kenya, which is also an issue in a number of countries, is decentralization of healthcare systems. So it's very easy for a national government to say, we're going to give free care, or we're going to give exemptions to this population, when it is the counties that actually have to provide the care and finance the care, or the districts or the provinces in another place. And this is also something that Catherine Muma foresaw, and something that is an issue with donors, because donors often negotiate with the national governments, and the Kenyan government can agree to lease financing expensive equipment or designing a social insurance scheme that systematically excludes the poorest sectors of the population. So that's the first thing I want to say. The second is I want to focus in on women. Because there absolutely are high cost cases in emergency care, as David and Annette both mentioned, but women is a little bit different because women have, by virtue of our reproductive health needs, we need maternal health care. And that has been declared not just a violation of the rights that Dave listed, but also discrimination in establishing a health system that does not meet women's distinctive health needs. That's been very well established under international law and under Kenyan law. And also, it seems to me that if we are estimating financing needs for pregnant women, that is not a massive econometric challenge, because you can calculate the number of women of reproductive age, you can calculate the total fertility rate, you can calculate an estimated unmet need for emergency obstetric care and finance that. Now, the question is how to get the funds to facilities. But this seems to be an area where use of digital technologies, M-Pesa in Kenya, and other private sector initiatives could be really, really valuable to tackling this problem.
Thank you so much, Alicia. I want to ask you one quick question. Dave's presentation talked about countries' commitments to all these declarations at a global level. There could be a right to health being a constitutional issue. How do you think we can realize enforcement of these legislations? Because they are in place and we still have this vice. In 1 minute, please.
Right, so in some places, the legislation is in place. In Kenya, it is in place. It's, again, a matter of regulatory and compliance, and that's a problem throughout the Kenyan health system and throughout a number of countries' health systems. Health systems often function to exclude and marginalize people. So that is a different set of legal problems. My own view is that it's probably a matter of carrots and sticks. Rob mentioned prosecuting people in hospitals. I'm not sure that that is certainly not the exclusive avenue, but possibly one. I think that criminal prosecution should only be used in a last extent, and it's probably not good to aim it at the providers who have very little control, but further up the chain of authority. I think there are a lot of other things we can do to help enforcement in terms of enhancing regulatory compliance, but also giving patients actionable information. So if there are facilities that are detaining people, make them publish that. That is a regulatory issue where they have to publish on a weekly basis. Kenya, which again is the country I know best, has wonderful civil society organizations, has a human rights commission, has a gender equality commission, which could be engaged in monitoring this and putting pressure on those facilities, including the approximately 50% of the facilities in Kenya that are faith-based and private.
Thank you so much, Alicia. Now I want to come back to some of the key questions that came through the chat, and I want to put 3 questions to Dave. One of the participants is saying, do we expand the definition to include hospitals that detain documents, death certificates because of non-payment of fees? But also another participant is saying that this could be disguised as long waiting times. Please, I would love you to comment on that. There are 2 questions and I'll ask both of them, then give you the floor. The other one is doctors who pay commission, hospitals who pay commission to doctors to refer patients abroad. What regulatory instrument do we look at, and how can we also address that issue? So I think I'll let you answer those 2, and then I'll raise some questions to Inka.
On the first one, the question of expanding the definition. I think we're most concerned about detaining people in hospitals. And as Alicia and Rob and Annette highlighted well, the tragic cases of people being detained in hospitals against their will, and also tragic cases where loved ones can't get their deceased loved ones and bury them. This is a terrible situation. And I'm not sure that we are so concerned about the release of documents. Though, of course, if it is impeding people's, if it is acting to impede other people's rights, then that was something we want to look at. But as a priority, we're most concerned about getting people out of hospital. We're most concerned about getting loved ones to their families so they can be buried. Sorry, what was the second question you wanted to ask?
Hospitals who pay a commission to doctors for referring patients abroad.
People overseas. Well, I mean, this is an important policy question for countries. I've worked in a number of countries where people perceive that that healthcare is better in overseas jurisdictions. Unfortunately, it often seems to be the rich people in the population who have access to the ability to travel overseas to get access to healthcare. I think as much as you could regulate this sort of practice, it's also about improving the quality overall of domestic health services and making sure that everybody has access to the domestic health services they need, not just to those that are available overseas. It creates a big equity issue. It's quite inconsistent with efforts towards universal health coverage if people can be incentivized to send folks overseas when they could be receiving care at home.
Thank you so much, Dave. Now I want to put 2 questions to Inka again from participants. That is, one of the participants referred to this as the elephant in the room, that if private providers have patients who cannot pay and we do not want them to retain them, who refunds their cost? Because the government is not subsidizing care in the private sector, and in order to curb detention of patients or even bodies, who covers that cost? Then the other question is about the insurance, that private insurance companies rejecting payment of bills for some of the insured patients. Even the not so poor have suffered because of the way the insurance mechanism is operating. And I will ask you 2 questions. Allow me to add another one. It's about the unintended consequences. And maybe Rob, you could also comment on this. The unintended consequences that providers may change the way they handle this, that they refuse to admit patients who they think will not be able to pay on discharge. Then also another participant said that there was an effort to subsidize C-sections, and they saw a dramatic increase in the cesarean sections because that was a subsidized intervention. So let's start with Inka, and then Rob, I also request you to comment on that. Inka, please.
Thanks very much for these really interesting questions, and there are many more actually in the chat. And you raise important issues. In fact, the issue about private hospitals has come up a couple of times. Now, I should say initially that in our policy brief, we put a focus on public facilities and potential measures. But of course, the questions that you raise about private hospitals are equally relevant, and solutions have to be found. So who refunds these private hospitals? I think there isn't an answer that will address each and every country setup. I guess at the first thing, of course, no private hospital should detain a patient. I mean, that's the same rule. The question is, what kind of repayment schedule can a private hospital offer to a patient? And you know, I think meanwhile, it's probably much easier to follow up on a patient who hasn't paid. Maybe, you know, 15, 20 years ago, this was more difficult. A patient would sort of appear, but I think there are now probably more options to really set up a functional repayment method. The other thing is, of course, and, you know, there isn't any easy answer to that, but it was an interesting comment from somebody, you know, saying that it's not just the hospitals who potentially, you know, look what they can do. It's also the patients who potentially, you know, see which hospitals they use, and do they go to a public or to a private hospital. So it depends on, you know, the setup where they are. I think Juliette or somebody said it in the beginning, you know, no, it was Annette, sorry. Where do you actually go? I mean, you shouldn't, it's, of course, when you have an accident, you can't start thinking about where to go, but at the end of the day, family members or the ambulance could also support that question, where does the patient go? And then there was the question about voluntary health insurance that would not pay or that would not pre-authorize the hospitalization, or would not cover the whole areas. It's very tricky. Again, I mean, I think it brings us beyond just the question of hospital detention, because I think we're clear on the initial answer. I mean, there should be no hospital detention. The question is how to actually refund or how to reimburse hospitals. And here we really move into the question of how actually to align, you know, voluntary health insurance policies, whether these are in a supplementary role or in a complementary role with the existing public health insurance system or the public health coverage scheme. And again, this can be very country specific, but you know, if this is happening, to me, this points to a setup where in fact the voluntary health insurance policy is insufficient, is inadequate, and people actually shouldn't buy those. So it's the role of government actually to regulate quite strictly the role of voluntary health insurance and really look into the policies of what is covered and what's not covered. I'll stop at this point.
Thank you so much, Inka. Rob, do you want to take it from there?
Yes, and really following what Inka was saying about how one embeds these types of policies in a coherent approach to health financing right across the board. I mean, obviously hospitals, you know, being the public-private sector, need to cover their costs. And you raise the issue of, you know, sort of people being denied treatment, you know, because they can't pay their bills. Now, you know, where it's often the case that these types of medical detentions are occurring in absolutely critical emergency situations, often around deliveries or road accidents and people requiring emergency surgery. And there, you know, I would say that, you know, someone who's presenting at an accident and emergency department with maybe sort of half an hour decision, you know, about whether they're going to live or die or not, should be treated. And, you know, it really should be a case of treat first and then deal with the financing after that. Now, of course, you know, it's a situation that, you know, someone in a private hospital might then get presented with a bill and you know, that person gets discharged and the hospital is perfectly within their rights to sort of try and recoup that debt, you know, sort of later on. But you don't lock people up, you know, that's just completely out of magnitude with the cost. So I think, you know, very important that, you know, that all hospitals, you know, sort of do have policies that someone in an emergency situation is treated. Now, if someone turns up and clearly hasn't got the means to pay at a private hospital and wants to be admitted, then, you know, I think the hospital would be in their rights to sort of turn around and say, no, you know, you should go to the public facility where you'll be able to access those services, hopefully for free, you know, which is the situation in many other countries. So it's just a matter of making sure that you know, these policies are consistent and coherent with an overall financing policy. But quite simply, the best way to deal with this, obviously, is to have always an accessible option to access services free at the point of delivery in hospitals, and then this just doesn't become a problem.
Thank you so much, Rob. Alicia, I would put one question to you, but I would also love you to share something very briefly about the private provider perspective, drawing from your experiences in India, but I also have a question that I want to put to you. A participant shared in the chat that in the Philippines, the hospital detention law only applies to indigent patients. Should we look at this as a good start, or should we focus on an all-encompassing law that addresses everybody? Because, I mean, you're rich today, you're poor tomorrow. Your comment on that, please, on those 2 points, Alicia.
Sure. Well, I actually think the WHO report, on this last point, the WHO report is very illuminating, because the definition of indigence and the need to demonstrate indigence is very problematic, and to get an exemption. So I don't think that is a solution to the problem in the Philippines. On the public-private issue, this has been dealt with in a number of different ways in different countries. So there are solidarity and guarantee funds in a number of Latin American countries for things that are not covered by insurance. In India, where an enormous percentage of the healthcare is provided through the private sector, There was litigation against a large hospital chain, Apollo Hospitals, that required and ended up requiring private hospitals to provide a third of its treatment to indigent patients. Now that both of those situations are quite problematic. There was cream skimming. There is a reimbursement mechanism implementation problems in solidarity and guarantee funds. That we also have examples also in Latin America of where, and this deals with the unintended consequences problem, where you go to a facility, public or private, and if you're denied care at that place, say in abortion context in Argentina after this recent legislation, if you have to go to a second place to get care, the first place is charged the costs, whether it's public or private. And those kinds of mechanisms, I can imagine discouraging both turning women away and also detaining women. But again, I think that this is something that we need to look at creatively in terms of empowering women to have the financial resources, whether it's through M-Pesa or through some other mechanism, to go to the facility they want to go to.
Thank you so much, Alicia. Now I'll put one question to the country participants. It's about monitoring, because Inka touched on the issue of quantifying the burden and monitoring how we are doing on this. Now, Annette, I'll give you half a minute to make your comment, and George, again, half a minute on the feasibility, on the interest by countries to monitor this, and how do you think we can really build a case around this to generate evidence that drives discussions, but also more important, to fight the problem. So Annette, I'll give you half a minute, please.
I think countries should just generally seek to monitor, do more monitoring. The government needs to put in a lot of mechanisms for consultations, both with the public and the private, even as we think about having legislative solutions that will go from the national government to the county government for the case of Kenya. Thank you so much.
Thank you. George, your comment on this, please.
I think I would say, like in Zambia, we are not experiencing the detentions, maybe in the private sector, though most of them are being catered by the insurance companies. However, people should take advantage of the government, the public institutions other than private, because we have got little contribution towards the private control. You know, the government is there to provide welfare, but for the private sector, it's there to maximize the profit. So it's very difficult to put up a control. But otherwise, we should encourage the political will. If there's a political will, the way our president braved to abolish user fee, and everyone who refers to it, they are able to fear to say, no, if we do anything, the state can come in and protect the clients, of which it's a good thing. Thank you.
Okay, thank you so much. So we'll have only 2 questions, and then I think we'll be bringing this to a close. And one question I'll put to Dave, a participant is asking that can WHO do more than advisory, than talking about these laws and legislations? Can really WHO do more than that to make sure that there's action at a country level? Then Inka, briefly, I'll give you maybe 1 minute. Dave, I'll give you half a minute. Inka, I'll give you 1 minute to talk about 2 things. Again, your views on monitoring, because this is a core function of WHO since we monitor UHC in countries. But also, I think I can't ignore the comment from Nigeria, where participants are saying this is a rampant practice. It's one of the biggest economies of Africa, and hospital detention is the norm. So you touched on the issue of financing reforms. Maybe briefly, you can talk about options for such big economies, and the practice is rampant, and what reforms are we talking about? So Dave, I'll take it to you first. Can WHO do more?
Well, there's 2 things that we want to do. The first thing is, from a political economy point of view, we wanted to highlight that from the point of view of WHO, this practice is not acceptable, and we're supporting our member states to implement measures to stop it. So I think WHO publishing a document like this is a big message. The second thing I think that's really important is, and as Alicia said, we're not here to blame anybody, we're here to support. So we are here to support countries to address any governance or regulatory issues that they need to address to deal with this issue. And we're also here to support countries with any health financing reforms that they need to put in place to address this issue. So those there are two concrete things that we can do.
Yes, thanks for this really good question. I think we're really sort of digging deeper again into health financing policy. You know, I mean, independent of this practice of hospital detention, it's really about how do you reduce out-of-pocket expenditure, how do you increase the reliance on public finance? And, you know, the case of Nigeria was mentioned here, and I think Nigeria, I mean, don't quote me now on the figure, but so what I kind of remember out of by heart is, you know, there's 65 or even more % of the current health expenditure coming from out-of-pocket expenditure in Nigeria. That's obviously way too much. So what can be done? I mean, Nigeria is a large economy, lower middle income country with a very large informal sector, and it's very difficult to actually collect direct contributions from this population, and evidence shows that is actually not really helping to progress towards universal health coverage. So what can be done? Getting, you know, shifting out-of-pocket expenditure into prepaid, into pooled funding. One way is to actually do this through indirect taxation, VAT, because that actually, you know, puts a tax burden on everybody, but according to their ability to pay, according to what they actually consume, according to their expenditure. So it's I mean, the main message, and this simple message in theory, in practice, of course, very challenging, is to shift away from out-of-pocket expenditure into prepaid through indirect taxes. Now, Nigeria is in the process of establishing the state health insurance schemes. This works to a certain extent for the formal sector employees, where you can actually deduct direct payrolls. But again, it's not the solution for the large part of the population. Again, you need state budget transfers, you need general government revenue to support these state health insurance funds to cater for those who cannot contribute directly. So maybe just as a final sentence, again, important to make sure that there aren't any then distortions created in terms of formalization, informalization of the economy through the setting up of the state health insurance schemes. So again, main message, largely rely on public finance through indirect taxation.
Thank you so much, Inka. Now, participants, please allow me to wrap up our session. And I'll just recap on key messages that came out of our discussion. One is hospital detention for financial reasons is a serious human rights violation and should never occur. Persistence of the practice is contrary to countries' commitment to UHC and will put progress towards UHC at risk. There's a range of legal mechanisms for stopping hospital detention. As we have heard in the session, foremost, there's need to ensure that patients and their families have access to advice, to legal assistance, and mechanisms for reporting and resolving breaches of rights. Legal measures, however, will only work in the long term when accompanied with health financing system reforms to address the underlying causes of uncompensated care, both in the public and the private sector. And countries where hospital detention takes place need to urgently engage in UHC-oriented health financing reforms, coupled with the short-term measures, as we heard from David and Inka's presentation, but also through the panelists in the session, and to have immediate solutions. We need immediate solutions to this problem. Ultimately, the need to ban hospital detention should receive much greater attention from the national policymakers and international community. And we could see from the poll, there was a 17% who were not aware of this, and in 70%, I think it was 7% of responses, it wasn't occurring. But again, it's the issue of data. Are we aware? Are we monitoring these things? So the international community is asked to provide specific support, including financial resources to countries whose people suffer from hospital detention, to assist in stopping the practice immediately. And to this, I want to add what Rob touched on, that monitoring compliance. You know, we commit to these things, and we don't follow up and we don't monitor whether we are really doing what we promised to do at all levels. And the international community should help countries to implement legal provisions to stop hospital detention practices and monitor their effective implementation. Now, these are our take-home messages, but I also want to emphasize that we want to keep the discussion open. So we can share documents, we can share experiences to keep this community alive and the discussion alive. And also, more important, to support our countries and also to influence where we're able to influence. So, ladies and gentlemen, allow me to really thank our presenters, our panelists, but also to thank you, the participants, very much. So everybody, thank you very much.